Hello there, I'm Ian Lewins. Welcome to Two Peds in a Pod. And here's what's caught my eye in the medical journals this week. Today we're talking QTC intervals. Yes, those cryptic little squiggles on ECGs that make resident doctors sweat, GPs reach for cardiology referrals, and ED clinicians go, please don't be long, please don't be long. Because here's the kicker. Automated QTC intervals on paediatric ECGs often lie, not in a villainous moustache twirling way, but enough to mislead clinical decisions. I want you to imagine this scenario. You're in ED and a child presents with a funny turn, and they're on a medication like ondansetron, or they've got a family history that just makes your spider senses tingle. So you quite rightly decide to run an ECG, and the machine spits out a QTC interval of 460 something milliseconds, and your heart sinks. But should you panic, and should you even believe that number in the first place? And this is exactly the issue a group of paediatricians from Louisville and Nevada decided to investigate and published their results in October's edition of Pediatric Emergency Care. So in this study, a team of paediatric cardiologists reviewed 200 paediatric ECGs. And what they then did was compared their measured QT and QTC values against the machine-generated QT and QTC values. And here's what they found. Number one, the machines consistently overcalled the QT and QTC values by 25 and 30 milliseconds respectively. And number two, almost 10% of paediatric ECGs were flagged by the machine as having either a prolonged or borderline QT and QTC interval. However, when accurately and expertly measured by the cardiologists, only one of the 200 ECGs was considered borderline prolonged. 1 out of 200, not 10%. And number three, when they used more modern formulas to calculate the QTC compared with trusty old Bazette's formula, QTC equals QT over the root of RR, that one, they found that the intervals were even shorter. So essentially, Bazette's overcooks it, particularly at high heart rates, which kids are annoyingly fond of. So what does this mean for us ED clinicians? Well, it means that the machine isn't being malicious, just overly dramatic, like that one person who thinks that every rash is meningococcal. But in Peds ED, this matters, because overcalling QTC prolongation might lead to unnecessary admissions, unnecessary cardiology referrals, and certainly a lot of familial anxiety. So I guess the takeaway here is that the machine-generated QTC is a suggestion, not a diagnosis. So how might we, ED clinicians, handle this if we haven't got a friendly paediatric cardiologist to hand? Well, one strategy might be as follows. Firstly, let's just eyeball the rhythm. Does it look sinus, or does it have weird stuff on it? Secondly, and probably most importantly, measure the QTC yourself and have a bit of a checklist in your mind as what you might consider prolonged. As a rough guide, less than 440 milliseconds is normal. 440 to 460 you would consider possibly borderline prolonged, and more than 460 consider a prolonged. But remember, context is key here. What are the symptoms? What's the family history? And is the child on any relevant medications? So the next time a paediatric ECG tells you there's a prolonged QT, don't let your pulse race. Machines can misjudge, humans interpret. Stay curious, stay calm, and stay skeptical of automated squiggle analysis. I've been Ian Lewins, and catch you next time on Two Peds in a Pod. Thanks for watching, and if you're enjoying this series of videos, please like and subscribe and tell your friends. Remember, machines lie, but toddlers don't. Unless, of course, it's about washing their hands.